Hi, I'm Betsy Nicoletti. Thanks for joining me today to watch this short video that goes along with a longer article on coding intel. And in it, there is good news. Now, have you ever heard me talk about an OIG report before and say, wow, we have some really great news? Well, we're going to hear about some good news today. Now, we'll do some good news, and then there are some maybe learning objectives or things that we might be able to improve in our telehealth documentation. But I think for most of you watching this, when I get to the recommendations or my thoughts on what the OIG report says, you're going to say, we already did that. We're good. So let's not look a gift horse in the mouth, right? We don't have gloom and doom here. So the OIG audited 110 encounters out of 19 million, but it's a stratified sample. That's how they do these things, of E&M telehealth services that were performed between March 2020 and November 2020. I don't even like to think back on those months. And not just because of all the coding changes, of course. So they looked at 110 encounters, the identified telehealth claims by those that either used place of service 02 or modifier 95, G2, GQ, or G0. And this wasn't this was really just a random sample. They had already released a report of 1,700 providers who they identified throughout the country as being, as Medicare of being at risk of being billed incorrectly by these 1,700 providers, mostly because of sheer volume. Who could have billed that many services in a 24-hour period, that kind of thing. But first, before I got into the report, everybody should take a bow. If you were working back then and getting claims paid, you know, we remember we had March 2020, there was a Medicare quote final rule. April 2020, there was another one. They kept upgrading and updating the variances and the waiver updates. And then, of course, there were the grids, because that was just Medicare. And other payers had different rules about both which codes we were using, what place of service, what modifier. So again, take a bow if you got your practice paid during that time. Of the 110 records that Medicare looked at, 105 were accurate. And here's a sentence I have never read before in an OIG report. This report does not have any recommendations because providers generally met Medicare requirements when billing for E&M services provided via telehealth. And the unallowable payments we identified resulted primarily from clerical errors or inability to access records. How do you like that? And CMS, you know, so the OIG does the report, does the audit, and then Medicare is given a chance to respond to the audit. Usually they're responding to problems, but they didn't even respond to this audit. So the OIG did note a few things. Now remember, this was 2020, the first 9 months of the pandemic. They noted that time was not always documented in the record. Of course, time isn't required. You could, back in 2020, we were still using the old guidelines where we needed 2 of the 3 key components of history, exam, and medical decision-making for established patients, all 3 for new patients. But one of the early waivers that Medicare gave us was use either time or medical decision-making. We understand you're not in person with the patient. So time was only required if you were using time. You could also use medical decision-making. From the note, they couldn't always tell if the patient was new or established. I don't see that as a huge deal. They're going to know from the code that was submitted. Mostly I see whether it's a new or established patient, but sometimes it's not written in the note. It's not required. And then, oops, some providers didn't sign the note. I don't know if maybe that was some providers who were still using paper records or dictating notes and didn't go back and sign it. But of course, the legible identity, and the signature of the billing practitioner needs to be in the documentation and in the notes. So some of the telehealth issues, I believe, when I tell you these things, you're going to say, we did that already. So it wasn't indicated if it was audio only or audio visual. Now, the OIG didn't count this as an error during this time period because the Medicare, and they're only dealing with Medicare patients, Medicare had parity between, and still has parity as I'm recording this in February 2024, between the payment for telephone only codes and audio visual. So they said, even though we couldn't tell, we didn't end up paying any more money than we should have. If we see this today, of course, that is a problem. We want to know if it was audio only or audio visual real-time communication. Some payers don't have parity. We're using different CPT codes for it. I still occasionally see it in a note, but the vast majority of the telehealth notes I see tell whether it's audio only. It says, I was on the phone with a person, or it said it was audio visual. The OIG said that the software used wasn't described. I don't remember that being a requirement. My memory could be faulty. Currently, HIPAA compliant software is required, and that some notes didn't note the location of the patient or the provider. And I do think that our templates do tell us where the patient is. Back in November, in those first 9 months, sometimes the provider was at home too. Now I think mostly we're back in the office. Not mentioned by the OIG, but my two favorite suggestions for telehealth: don't use a template with a physical exam in it, because if you forget to take it out, it's not real. And if using time, remember, we're using visit time, not pre and post time if it's telephone only. So that's just one thing to keep in mind. The telephone only codes, when we are using telephone only codes, are based on the time of the encounter itself, whereas office visit codes can include pre and post time. So when we're doing telehealth, we've got to be clear about that, depending on which way we're doing it and how we're documenting time. Now, they did something that surprised me. They went back and talked about the 1995-1997 E&M guidelines. Now, we know that those guidelines, which we're not currently using now, were a joint work product of the American Medical Association and Medicare. I think that's all I'll say about that. The AMA now, in their CPT book and in the CPT assistant, say that the code set is not meant to be documentation guidelines, that they're not providing guidelines. But the part that the OIG, too many initials, the part that the OIG went back and looked at were the general principles of documentation guidelines. And in the report, they said, we hope Medicare is going to update these guidelines. I don't see that happening. I haven't heard a bit of that, but I like these principles, and I think they're worth reviewing. The medical record should be complete and legible. The documentation of each encounter should include the reason for the encounter and relevant history, exam findings, prior diagnostic test results, assessment, clinical impression or diagnosis, plan for care, and date and legible identity of the observer. You know, if I could needlepoint, which I cannot, wouldn't that be a nice thing to needlepoint and put up in the room? I'm just kidding. But I do think number 2 is important, and I think it is worth remembering. So even though here in 2024, history and exam are not key components, they're not, we don't have, they're described as they should be medically appropriate, and we don't have a definition of medically appropriate. A good patient encounter says why the patient came in, what the history is related to why the patient came in, We don't need a physical exam. There even prior to these new guidelines, there were visits at which the patient said, no, I didn't, I just came in to talk today, and there wasn't a physical exam, maybe general observation. And then, of course, the assessment could be the diagnosis, the impression, the symptom, if we don't have a known diagnosis, and the plan. And let's not forget the date and legible identity of the observer. If it's not documented, the rationale for ordering diagnostic and other ancillary tests should be easily inferred. So you have a patient who comes in for follow-up for diabetes, and you do a hemoglobin A1C. You don't have to say, I'm doing this hemoglobin A1C because they have diabetes. I think that is easily inferred. Past and present diagnoses should be accessible to the treating or consulting physician. We mostly have that, especially with our EMRs. Appropriate health risk factors should be identified. The patient's progress, response to, and changes in treatment and revisions of diagnoses should be documented. We're going to find that down in the assessment and the plan. And then, of course, the CPT codes reported on the health insurance claim form should be supported by the documentation in the medical record. In a perfect world, and we're living in a perfect world, right? So you might want to read this report yourself. The OIG reports all have all caps for their titles, so I used all caps here. You could click on the link, but you're watching this. If you just copied down OIG A-01-21-00501, and you put that in your Google search box, you'll find the report. Thanks for joining me today. I am really delighted to be reporting on an OIG audit that had such good outcomes. And in all sincerity, anyone who was working in medical practices or in a hospital trying to get claims paid in that first year of the pandemic, really, pat yourself on the back. You did a great job. Thanks. Hope to see you again.